I think it's important that we have information that's reliable,
Yep.
that's not hysterical, and that women know what the real information is regarding pelvic floor disorders.
All right. I am so excited this morning to have on the podcast one of my very, very, very first pelvic health, women's health mentors, your gynecologist, Dr. Cheryl Iglesia. Thank you so much for coming on this morning. I really appreciate it.
Oh, Dr. Pagliano, I was thinking about this. We go back 23 years.
We go back a long
When,
time
mhm,
when I
and
had no idea what I was getting into. Yes.
and now you've really have created such a strong program in the DMV. I'm really proud of you.
Thank you. Well,
I'm also happy that we serve on one of the advisory boards together at
yes.
NCAPS.
No, it's always I don't think I realized, so just to history, my very, very first job in pelvic health was at National Rehab Hospital,
Mhm.
and a couple days a week, we went over to your office,
Wow.
and I had no idea at all what a force you were in the field, and lo and behold, as I kind of gradually, got a little bit more experience, and I'm like, "Wait a second, like, I was in the OG office, like."
Uh-oh. I think that's what happens. They call you the OG when you get this much gray hair.
Right. But you're also again, like I saw you've been on Twitter since 2012. I feel like you're one of the first
Mm,
like medical providers that have kind of used that space professionally to get the word out on a lot of things before it was kind of a thing. And
yeah.
I see so many more people that are kind of following your footsteps. And I mean, in my field, we tend to we tend to gravitate a little bit more towards Instagram, but like I
Yeah.
feel like it's such if you go back to the history, trailblazers like you were starting to put things out and kind of voice opinions and bring information forward on social media. And so if it weren't for people like you, I wouldn't have a space or a place. And
Oh,
so thank you so very much for being a part of where all this kind of went.
yeah. I
So
think it's important that women get reliable information because, as you
yeah.
know, social media in particular, um, there's so much marketing and
Yes.
some shystery stuff
Yeah.
out there that it's hard to discern, truly. It's really hard to discern, like, who are the experts, what's real. There's enough anxieties that women have about their own
Yes.
bodies and things that happen after the baby is born that we don't need to add fuel to the fire. And I think it's important that we have information that's reliable,
Yep.
that's not hysterical, and that women know what the real information is regarding pelvic floor disorders. So
Yeah,
kudos to you
absolutely.
and everybody in the women's pelvic floor.
We are trying. We are trying. So one of one of the diagnoses that I get the most questions about, and I think there's the most fear surrounding, is
Mhm.
pelvic organ prolapse. And I mean, you've obviously seen this your entire career. You're very familiar with the surgeries, the history with mesh. That brings about a lot of fear for a lot of women, even though that was, a very, very long time ago. Like, how do you see that the management has changed, and then also the messaging behind, this is what pelvic organ prolapse is, these are your options, this is your future?
Yeah. So things have changed, and most of it. I want to just assure women is for the good. Yes, there have been some outliers with regards to vaginal mesh, but let's be real about some of the innovations that have occurred. So, when I first trained 30 years ago, when I did my fellowship, most of the surgeries that we were doing, and again, surgery has always been the same. We always think of medical management, pelvic for physical therapy, weight loss if it's necessary, pessaries,
Yep.
local therapy if at all possible, prior to surgical correction. And when I was training way back when, there were really only two approaches. You can go vaginal, and that generally was without a mesh, or you could go abdominal with a big open incision that would require 3 nights in the hospital
Wow.
and, like a 6 week recovery minimum. So, now we're taking it to the mini. Everything is in the vagina. And laparoscopic or robotic, so that the majority, and I want to say over 90% of the surgeries that we do for pelvic organ prolapse, if it's necessary, are actually outpatient. And the meshes, yes, there have been some debacles. I mean, when I first trained, we were using Gore-Tex. Could you imagine Gore-Tex? It's the same that you use in your raincoats. I mean, it's the same company. I don't no disrespect to the Gore-Tex. It's great for my ski parka.
Exactly.
But it really wasn't great. And we've written about this, and that was kind of on the learning curve with the way products were introduced. I think we've gotten better at the FDA, and I'll just disclose that I have been a special government employee for the FDA, and I was on the panel that served on the vaginal mesh review back in 2011. And we were one of the first sites that actually did one of the clinical trials that showed that there were some complications with mesh. But, I'm here to reassure women that mesh, when used judiciously in the right patients by the right surgeons, is safe by and large. And you want to go to someone who's doing high volume and can not, just sway you into surgery, and can offer physical therapy and pessary management and whatnot prior to just going to surgery. I see that a lot. I see women who are, I guess, kind of turned off because, yes, I have a rectocele, and the first thing that doctor wanted to do is like go ahead and book the surgery.
Right.
And I think women are savvy enough to know that that's not the way that they want. They want to be educated. This is
Right.
elective. This is,
Right.
by and large, unless you're like, kidneys are being completely compressed, the ureters or something,
Yeah.
or you have a fistula, which is an abnormal connection, say, between the bladder and the vagina, or the bowel and the vagina, and urine just pouring out or stools coming out. By and large, this is elective. When I say elective, I don't say cosmetic, I say
Right.
elective. And we have to do it at the right time, and we need to know the options, and we can't just have one size fits all.
Yeah. No,
And
definitely.
that's the thing. I think some people are like, oh my God, I had this baby. And let's get real, because the statistics on this. When you have a baby, and this is probably a 40-year-old paper, manned out of England, a clinic in England. He was a gynecologist who just followed women. He delivered them. And this is when you were the same gynecologist from
Right. The whole time.
cradle to grave, right? And saw that when women had one baby, the risk for developing prolapse was fourfold over someone who never had children. After two babies, that risk is eightfold. So things happen. Most of the time, it's not the end of the world.
Yep.
Sometimes you can have significant damage that occurs. Some of it could be related to the way the baby was positioned, like sunny side up, or the fact that they had to use instruments like the forceps, which are worse than vacuums, or the fact that the baby was very large and unrecognized, or the fact that you're actually genetically predisposed to this
Right.
because your mother had it, or because you have hypermobile connective tissue
Yep.
disorders. For the most part, this is treatable. And for the most part, we should start with conservative management before
Right.
thinking about surgery.
And that's when I have clients come, that's one of the first questions I ask. I'm like, if you've seen somebody, like, first of all, where did you go first for your information? And then if you talk
Oh,
to somebody or a surgeon,
hmm,
what was the first thing that they told you to do? And are you here because you wanted to be here, or are you here because your surgeon wanted you to be here, or both? Because the best surgeons that I have found in my career are the ones that they see the benefit of conservative treatment pre-op. And the thing is, there's nothing to lose. You know this. Like, if
right,
you do conservative treatment before, and worst case scenario, it ends up being a surgical case, you're 10 steps ahead to being, great outcomes on the post-op side. So there's
right,
really nothing to lose.
right,
But
right.
it's, again, I think people,
Now, some people want to get things, all the
they want
junk
it
put back in
fixed.
the trunk
Right.
before they actually were. And I'm okay with that too. I said, you know what, we're gonna put the junk back in the trunk, but we are going to actually refer you to Dr.
Yeah.
Pagliano and colleagues, to work on this, because I think the longevity,
Yes.
we want you to, preserve that pelvic floor just for future,
Absolutely, and
you
and
know.
preserve that surgery site. I had a
Mhm.
client recently, unfortunately, she contacted me the day before, a rectocele repair, and she was
Mm.
21.
Uh-huh.
And I was like, "Oh my goodness, I
Yeah.
wanna understand
Yeah.
why this happened,"
Yeah.
because we have we've got about 70 years that we're gonna, try
Yeah.
and work on this
God
and
willing.
right?
Although I think it's dropped a bit because of COVID. It was
Oh,
70
oh, oh, no, don't say
it was
that. Oh.
70 I think I don't know, I read something in JAMA recently, but yeah.
No, I read the same thing. So, all right,
Yeah.
so we'll see around, like, we'll work on that. But either way, it's
But
a
we're
long
optimistic,
time.
so it's gonna
Right.
be 87 for
But for an active female, and I felt so
Yeah.
bad for her because we
Oh, yeah.
could she did the Google search and the only information she could find was postpartum, and that discussion was not had with her surgeon.
Mhm.
And so that's where we've
Mhm.
spent a lot of time, and she's an athlete. Like, how do we work back to this when we don't have great
Yeah.
data? But how do we use what we have and be smart about this so that you can still be active? You're not worried about things, but
Yeah.
we can make methodical, intelligent, intentional decisions moving forward. So
Oh, yeah. And it
there's
needs a
still
full
frontiers
workup.
out there.
Yeah. You know what? And I think that that's what you have to look at when you're looking for a provider, and particularly someone who's thinking about surgery.
Yeah.
How are they listening?
Yeah. Right.
I'm going to be honest. I mean, fortunately, we have fellows and residents and everything, but how are they listening? Because, okay, yes, we can talk the history, what prior medical, what surgical surgeries have you had, et cetera, et cetera. But sometimes that social history is
Yes.
more importantly. What is that woman doing on a regular basis? Is she sexually active? Does she want to be sexually active?
Yes.
Does she have an occupation that, blah, blah, blah.
Right.
I feel like that gets lost a lot nowadays. And understanding, we've written about this, patient's goals, so that your goals match what the surgeon can provide, and you're not
Right.
at two different levels,
Right.
thinking like I'm going to be like I was when I was 21 or even before the baby was born, what we can really deliver based on, neuromuscular, the current issues
Yeah.
and
Well,
what
and
needs
I
to be
I
helped.
I feel like too the goals now compared to 20 years ago are actually incredibly different. I mean,
Yeah.
I've lived in Arlington now over 20 years, and we're a really super active community. I think we're like one of the most active in the United States, and I would say that
Yes.
about the DMV.
Yeah.
And I think my generation, particularly like our moms were still doing exercise for weight loss. It wasn't necessarily just for fun or things like that. And
Yes.
so it's really interesting watching moms now navigate exercise because that's their identity, that's who they are. They're running marathons. I mean, the winner of Kona yesterday,
Yes.
she's 18-month-old. I'm like,
Wow.
oh my
She's
gosh. And I
a
think she
mother of an example.
unreal with an 18-month-old, and
Unbelievable doing
I'm
the
like,
triathlons.
and she's
Yeah.
a rookie, I think, in America. Just like, I love it. But we're
Mhm.
having so many more examples of moms in the professional space at a high activity
Serena
level.
Williams. Yeah.
I know. I
Good
know.
for
And
the
so
good
I
for
think it's
that.
great that we
Mhm.
have these examples, but that's not what we were treating 20 years ago. That wasn't the goal. And so I think to your point, like understanding um,
Yeah.
what CrossFit is, for example. Like we poo-pooed that for a really long time, and lo and behold, 6 years ago, I took the jump. And so,
Right.
and you've lifted some weights before
I've done it
too.
too. I have to be careful with my shoulders when we
Yes.
were
Well,
yeah,
sure.
but
Yeah,
but I love it.
we
Yes.
don't have to snatch all day, but
Yeah,
like,
yeah.
but to your point, like you're an active person too, like you understand that, and that's been an evolution for you as well. And so I think it's so great to
Yeah.
have providers that are going to step out and understand this
Mhm.
space and understand what activity looks like. So
And I
um,
actually think that that's really important because,
yeah.
as we're changing and as there's new minimally invasive approaches, you know, if we put mesh in, for example, that mesh, that could be in with you for, 50, 60, 70
Yeah.
years potentially. So I understand that. And so some people, I think we've loosened it. And I actually wrote a paper for JAMA, an editorial on this, is that women are more willing to accept failures or recurrences,
Yeah.
just like you would with let's just say your abdominal wall,
Right.
or your facelifts, that things, the native tissue is going to thin out, and there's going to be some issues related to connective tissue and the muscle,
Yeah.
even with the most fit, with the most nutrition, the best nutrition. And so we understand the effects of aging and the effects of gravity. And I think more women are willing to accept that we might need to do a touch up,
Yeah.
work on the muscles, whatever, rather than a complication,
Yeah.
So
Yeah.
I think that conversation is important. I also think, like I had a woman yesterday, she's 42, she's had 2 babies. She wants to go for the girl, she wants one more.
Yeah.
There's prolapse. I was like, the timing of this,
Right.
do we fix this? If we fix this, then a lot of people would say you might have to have a C-section for that next one. Or do we just wait to,
Yep.
finish with the next one, and we'll do
Yeah.
something conservative for now? I mean, there's so much conservative therapy. You don't have to go, say, if you're
Right.
leaking, you don't necessarily have to go with a mesh sling. You can go with a pessary. You can physical therapy. You can even we have better bulking agents now
Right.
that are more water based.
Yep.
Yeah, they're not permanent solutions, but it's a
But
good
it's options.
alternative.
Yes. And I think that's the conversation that I try and have so much with,
Yeah.
if people come to me first looking for conservative options, I'm like, there's a limit to sometimes what I can do based on why you're having this problem. But I don't want you to be afraid of, like bulking agents or things like that. It doesn't mean you failed. It doesn't mean you're broken. It doesn't mean you're messed up.
Right.
That's just not something that I can do to impact that. But this is a great option that might actually help you manage your symptoms so that you can be more active. So I think conservative is a lot more broad than people realize. But I
Mhm.
think, when they get worried when I want to refer them out, I'm like, look, if you come to me and you have not seen a specialist, I'm really picky about A, when I refer, and B, who I refer you to. So
At on the flip side, and I'll say the average age of people that we're operating on is actually 51. Most people
Mhm.
think, oh yeah, you have all these seniors and the Medicare 65-year-old
It's
seniors,
before then. Yeah.
AARP types, but it's actually 51, and the
Yep.
youngest was 16, and the oldest was 97.
Oh my
That I've
goodness.
actually done public reconstructive surgery on. But the bottom line is, there are many women who, yet they have completed childbirth. This is pretty significant, has a significant impact. They want to run that Kona.
Yeah.
Um, and they get the surgery and they rehab and they see people like you and they're like, I wish I had done this
I
sooner.
know.
So there's that too.
I
So the
know.
timing is important, understanding the options. You have to feel comfortable, with the person doing it, and
Yeah.
understand that there's a whole team, like
Exactly.
working with people like you. But this is all really treatable. It's not like you're doomed to a life of sitting on your armchair.
Exactly, exactly. Well, one of the other things that I was thinking about that's kind of changed over the past 20 years, and it is really kind of the understanding of muscle activity and tone. And when we were first working together, back in the early
Yeah.
2000s, like really, if there was high tone or overactivity, it was purely in the context of painful sex or dyspareunia or those sorts of things. Like it wasn't necessarily a consideration with pelvic organ prolapse.
Mhm.
And I feel like our understanding has evolved, I think more for me when I've gotten involved in postpartum return to sport and seeing women who were more active, kind of higher tone sorts of things. They would still be continuing to work out and we could manage that, but they would have, sometimes
Oh,
symptoms of
yeah.
pelvic organ prolapse, that kind of protective, hey, I feel something, I'm going to reflexively drop an in. And so I was wondering kind of what you've seen over the years as far as, with pelvic organ prolapse, the evolution of kind of understanding muscle
Mhm.
activity and responses and so on.
Yeah, I think this is a really important concept, and it's not really in our surgical textbooks to either. But like, for example, that 21-year-old that you were talking about, I
Yeah.
suspect he was probably high
Oh,
tone.
yeah. Oh, 100%. Like even
So,
before I saw her.
okay. And so A plus, and it's A plus plus on those pelvic floor. It's almost as if your sphincter tone is too tight. And so
Yeah.
anything we do surgically is not going to work because that person's going to continue to be straining, won't know how to relax.
Yep.
And there's sometimes there's just this, it's just out of tone, it's out of synchrony.
Yeah.
We call it dyssynergia, but literally your sphincters are supposed to be relaxing when the organs are contracting to get urine and stool out
Yep.
most efficiently. But if there's an incoordination of that relaxation and contraction, things go haywire. And so that needs to be corrected up front. And I do say that there are a lot of surgeons who don't understand that. And, to some degree, even the way we measure the pop Q, we measure the
Right.
pop Q, which maybe your readers know about, but there's a way we grade prolapse. Basically, normal is no prolapse. Like stage 1 is like halfway down. Stage 2 is anything to the opening. And most people who are like at the opening or above don't complain. Stage 3 is all the way out. Stage 4, and stage 3 is halfway out. Stage 4 is all the way out. So there are some people who have these very high tone that feel really, really bothered by little prolapse. But the fact of the matter is, it's the muscles so activated, and it's so nice to have people who can work on that, because it's almost like a cognitive behavioral therapy.
It's like I equate it actually to how we work a lot with chronic pelvic pain, where you have like a hypersensitization.
Yes.
And again, with this part of our body, it's not like our hands and you get a lot of sensory information from it. It's like peeing, pooping, sex, and childbirth. Like that's a really broad.
Yeah.
But you get these women, especially in our area, that just hyper focus and and you can test them in any position and you barely see anything.
Right.
But they definitely experience it all the time. They're terrified of it. It makes it worse when people say I don't see anything. And so that's one thing that I think it is really challenging to work with. If you just tell them, no, you don't have prolapse, it's fine. I'm like, no, they very much feel this. We've got to address that hypersensitivity, that overactivity, kind of all that other stuff. So
and we're getting all these, we're doing exams, sitting and standing, straining, etc. We're getting MRIs, and we're telling them we don't see anything, nothing's wrong, it's in your head, blah blah blah, when really it's really in your pelvis, and we need to get people like you. So that, I agree. I think for the most part, people who have like the stage 3s and the stage 4s, the significant prolapses, they most likely have decreased tone. We get and issues with connective tissue supporting
I would
these
agree.
organs. So we fix it, and then we want them to rehab as well, either before or after the surgery, at least after, preferably before, but both are fine. And there are some women where you can do all that, but Carrie, it has there's significant neuromuscular connective tissue abnormalities that really you get frustrated because you can only go so far. And then that's where we look at added stimulation. We've got neuromodulation. We've got other things that I want people to know. Don't give up. There's things that we can do, particularly when the organs are in place, yet you're still having issues with bladder and bowel control.
Exactly. And again, I think that kind of comes back to, when you're a patient, you're first kind of encountering prolapse, you think, oh, well, there's just one thing, when actually it's so important. And again, as a provider, I think it's so important to kind of understand how they got there in the first place, that there's not just one pathway, that they can walk in with some predisposition to pregnancy. And then it's not just what happened in that delivery room at all. And I think it's one of those things that because we don't talk about it until that moment, then we're thinking, oh, well, it was just this, I should have had a C-section, when really it's your mom and dad in the collagen they gave you, so.
At the same time, I do have women who had like the 4th degree lacerations, where they have delivered, and it not only tears the vaginal lining, but goes through all the way to the rectum, tearing the internal and external sphincters. And they're the kind of patients who are like, I read all the baby books. This wasn't in it. I had no idea this could
I
happen.
know.
And it is devastating. And you really do want to see a specialist
Yes,
who's like fellowship trained,
very much so.
do the
Very much
repair
so.
to specialists also for the rehab. But we can help people like that too. And like yesterday, I operated on somebody who had a baby like 5 months ago and has not healed. And
Oh
there's terrible
gosh.
tissue, and she's breastfeeding, and she's just feeling miserable about this because she's supposed to be going on with her life. And
Yeah.
we have to make some revisions sometimes because they don't heal. And honestly, the breastfeeding, we talk about vaginal dryness, and I'm going to confess I was on the group that renamed that vaginal atrophy to genital urinary syndrome of menopause. And
Hmm.
I feel like maybe we should just stop it at genital urinary syndrome,
Yep.
because adding that menopause in it, you block out a whole group of these women who are breastfeeding who
Yes.
have a lot of issues, because not just the nerves, connective tissue, muscles, it's the hormones, and they are
Yes.
very low on estrogen. And people are afraid we're not supposed to take estrogen when you're breastfeeding because your breast supply, and when really the local stuff is fine. And I felt like maybe if we had done some of that earlier on, she could have healed better. Anyway, she's going to be fine. We're going to fix it. But I'm just saying that's a whole lot of weeks and months of pain,
Yeah. No,
that
you bring up a good point
could
though.
have been avoided.
I was fortunate enough, Rachel Rubin, who you
Oh
know,
yeah,
she was at Georgetown when
my
we were there,
resident.
and
Yeah,
yep, exactly. So we
as was
spoiled her
Jocelyn,
early.
who
Yeah,
was another guest on your podcast. She's
yeah.
my former fellow.
So she obviously talks about estrogen a lot, and so does Justin Fitzgerald. And I feel like in my circles I'm so fortunate to have so many great physicians that promote early use of topical hormones. And it's so hard to say to a patient, this is what I think you need. How do we go back and have a conversation with your OBGYN about getting this? Because that message has not,
I know.
it's not come across the general population of providers at this point. Like what recommendations do you have to kind of help moms go back to the
Mhm.
provider and see if they can get this?
Yeah. I think we're doing a better job talking about the fourth trimester.
Yeah.
And I think that adding that pelvic floor concept to OBGYNs and midwives and family practitioners who do obstetrics, to understand that that is a component
Yeah.
of the symptom complex to pay attention to, in addition to thinking about women's mood and weight and their other cardiovascular issues and diabetes, etc. I think that that's going to get better. But obviously, I mean, you have a whole sisterhood here.
Yeah.
So women actually saying, I've heard about this on your podcast. I saw this on Instagram. I read about this. I do think I have this and I would benefit. And honestly, if someone's just not giving you the time of day, then maybe we go see somebody else
Yeah.
just for a little consult and a
Yep.
second opinion. Doesn't hurt, won't hurt my feelings. Sometimes I love it when patients have seen other people, because I'm like, I didn't think about that. That's a
Yeah.
fantastic idea.
Yep.
I'll be very direct if I think that's not good. I don't think using testosterone in the
Right.
breastfeeding is a good idea, to be quite
Yeah.
honest,
Yeah.
because
No,
we don't know about that, but
the
that
other
should be
thing
fine.
you mentioned was tissue healing. And one of the conversations I'm
Yeah.
also kind of having with a lot of musculoskeletal providers is kind of the incidence of RED-S, so relative energy deficiency syndrome, in postpartum women, which we typically think about it in female athletes. But the postpartum woman, besides all the hormone stuff, we've got nutritional deficit. They might be
Right.
over exercising. If they're breastfeeding, they're not getting a lot of sleep.
Yeah.
Again, those are all the things that you need to have good soft tissue healing.
Right.
So that's
I
just
know.
another place that, again,
Inflammation is not in our favor. Exactly.
no, I mean, but those are the things that I think moms are so overwhelmed with. Like if their kid isn't eating, or they're having bloody mucousy stool because you upped your protein too much,
Yeah.
or you're unhappy about what your body looks like, so you're going into calorie deficit, like
Mm.
there's a lot of bigger kind of sociological sort of, background questions or things you've got to ask to understand where they're coming from. Because like you said, oh, well, just, this needs to heal better. Okay, well, why isn't it healing? Why
Right.
are we having these issues?
Yeah, these are all really good points. And so,
Yeah.
yeah, I love working with and collaborating with other people besides surgeons.
Yeah. No. Well, that brings me to my last question.
Yes.
So great, the great segue there. So
Mhm.
for you, you're in this new role as president of the Society of Gynecological Surgeons. Congratulations.
Thank you.
And you have been a gigantic PT advocate for my
Mhm.
entire career, and I'm sure prior to that, with our mutual colleague Karen Liberi, she was the person that kind of brought me in with
Yeah.
you,
Oh,
and then
in
Jennifer
Ohio.
Chu.
Yes.
Those are the OG
Miriam and
PTs.
Reshma.
Yes,
Yeah.
Miriam Reshma. Yep, I
Mhm.
trained Reshma, and so
Mhm. Mhm.
so for you, like, what are some of the what have you seen have been the best kind of
Yeah.
attributes of great collaborative relationships between therapists and surgeons? Like, what are those things that you love seeing or
Mhm.
have really evolved into some great relationships?
I have to say, yeah, it's a big honor to be the 49th president and like the fifth women. There's been 45
Yes.
other white guys and 4 other women. So it's nice to have Brown Girl up here. And I would never
Yes.
have thought I could have done this. But what I'm really proud about from the Society for Gynecologic Surgeons is the kind of collaboration we do and the kind of guidelines and systematic reviews that we've done. We have been involved with looking at pain and sexual function after surgery. I think as surgeons, we are basically need to know when not to operate.
Yes.
And we have it's not just urogynecologists in the Society for Gynecologic Surgeons. We have all specialties, including the minimally invasive gynecologic surgeons. And as you know, our group is a group of 9 surgeons, and you know, 4 of them are minimally invasive gynecologic surgery who just deal with pelvic pain. I'm
Yep.
talking endometriosis, um, um, uh, fibroids, abnormal bleeding, but we also have painful bladder, interstitial cystitis, and all the myofascial stuff. What's been blowing my mind is new technologies, not just with the myofascial release, medications that we have, but even newer therapies, whether it be dry needling or low
Hmm.
light laser.
Right.
These are things that are on the horizon. There are studies that are going out there now that are going to be randomized, looking at say low light laser and sham. I think that the PT can take it to a certain level. And then what do we do after that? We
Yep.
don't just say you can live with this. I think that that's what we as experts in gynecologic surgery need to know, when to refer. And so I am so happy. And I actually, now that you bring it up, we've got 3 research engines. And one of them is the systematic review group. They're the
Hmm.
ones who talk about like sexual function, and I mean, all the stuff about mesh that you'll see and the big reviews have been written at Society for Gynecologic Surgeons. We have the Fellows Network, which is for the rising stars in multi-center collaborative research. And then we have a collaborative group known as the core group, which are for people who want to do multi-center sites. I feel like we should do something with the core and PT,
Ooh.
honestly. I don't see why we can't work
Yeah.
with IPPS, APTA, look at all
Yes.
these alphabet soup,
Oh, yeah.
SPS, and get some funding to do something like this, whether it be the timing or whether it be, because we have it all. We have all these people with IC, and everyone thinks it's one thing. We just do the surgery and we're going to, but it's not
It's
just
never that. It's never one thing.
no, we're going to do this. And we call it the hot potato sometimes because I'll say my partners, they'll treat the endometriosis and then they'll like, but she has some bladder pain, Cheryl. So I think you should see her now for the IC. And I'm like, okay, I'm going to treat the IC. We're going to fix the lining. And I'm like, hey, but you've got this myofascial component. But maybe we work together.
Yeah. Well, that's why I laugh, because there's so many people that I've worked with for so long that are, mutual colleagues of ours that are like, I don't know what's going on. Carrie will take care of it.
Yeah, that's the hot potato. You got the potato now.
Okay, but we're done. Not it.
Yeah, that's right. So I think that's what we need to do. And I know that Erin Carey and actually Susie Asani is our next program chair, and she probably has the most funding for people who have centralized pain. She'd be great for your podcast.
Yeah.
Anyway, Dr. Asani is her whole research is the centralization of chronic pelvic pain, and so that if you've lived with this for so long, yes, it's going to affect your brain, and your psyche. It's only natural, and so I feel like we need to kind of be a better communicators about the limits of what we do, and make it up front that this is the expectation that we're going to work together to solve. And we might not get this just with surgery, and it's probably more likely than not we're not.
Yeah.
So we're going to need to work on the muscle part. We're going to work on the psyche part. We're going to work on the pathology that we see, whether it be in the bladder or the bowel or the rectum, or in the pelvis.
Yeah.
And hormonal, and just kind of get through it together.
Yeah. Well, that's why I feel so incredibly lucky, is literally from day one of my work in pelvic health, it was always collaborative. And I know not everybody has that introduction. And to be able to work with people that, were such advocates for what we did and trusted us and our opinions and things like that. And so I sometimes I forget, and I kind of take that for granted, that not everybody is fortunate to have those kinds of relationships with the physicians that they work with. So I think, you provide such a great example, of, this is who you are. This is, everything that you do. You're always thinking of, who can we bring in? Who knows about this? Who knows about that? So I love that. That's just,
I love you too.
Collaborative. Love it. Love it. Love it.
We want to do the right thing for women. Awesome. So anyway, and I think hopefully you'll put some more resources on.
Yeah, no, definitely. And more conversations to come. So, but yeah, now it'd be great if we could do something with PTs and your association a little bit more. That would be great. Idea. So yeah.
Literally, let's talk to Susie.
Okay, sounds good.
We'll get the ICCS.
See, this is what you do. I always end up with like something to do after I talk to you.
It's hard to say no to me, right, Carrie?
It is. I know. It's like all right, it's guilt. I got to do it. So if you want to find Dr. Iglesia on Twitter, you can go to at Cheryl Iglesia on Twitter. Thank you so much for joining us. I appreciate, the big support that you've been for our profession, and, you're such a great advocate for your profession and clients and collaboration, and just thank you so much for all that you do.
Thank you. My pleasure.